Good morning, everyone. This is Karim Munemi with ViVitro Lab. Thank you for joining this exciting new webinar, the second webinar that we do on Redo TAVR. It's a very hot topic in valve therapy. Today, we have Dr. Fukui, who's going to join us with Dr. Tang and Stephanie Seller to talk about exciting development in this field. ViVitro is proud to support research at the Translational Lab in St. Paul, Vancouver, and contribute to the advancement of in vitro testing in the cardiovascular space and heart valve therapy. I hope you'll find the second webinar on Redo TAVR interesting and productive. Stephanie, David, thank you very much for hosting this session and facilitating this conversation. And thank you, Dr. Fukui and Dr. Tang, for joining us today. Enjoy the seminar. Thank you very much.
Great. Thank you so much, everyone, for joining us and attending this morning. We're excited, as Karim mentions, to have our second webinar on Redo TAVR and be joined by experts Dr. Tang and Dr. Fukui and Dr. Meier to discuss this from the bench and clinically and from some of the translational work that's going on to inform this evolving space. So we'll get started so that we can have the most time for discussion. So I'll hand that over to you, David.
Okay, thanks, Stephanie. So our first speaker today will be Gilbert Tang. So Gilbert, as most of you probably know, is the surgical director of the structural heart program in Mount Sinai Health System. And Gilbert, I think you are going to talk to us about the main concepts in Redo TAVR and indications. Please go ahead.
Okay, can you see my screen now?
Yes, looks great.
Okay, great. So thank you very much for having me here. It's been wonderful to see my friends again from Vancouver's group and also from Minneapolis Heart. So just a brief intro as a JAC editor and case report editor-in-chief. I'd like to encourage you, for those who are in attendance, to submit any interesting cases to us. We'll periodically have thematic issues. If you have a very good didactic set of videos or images to teach people how to do valvular heart disease or structural heart disease, please submit to us. We are an open access journal, and we look forward to working with you. So today I'm going to talk about the Redo TAVR indications, planning, and outcomes. And Miho is going to talk more specifically about the Redo TAVR app and some of the concepts. So I'm not going to cover those. These are my disclosures. And I'd like to personally thank the following friends and colleagues for leading this field of Redo TAVR and as part of our recent workshop last year. So I think this slide tells you that what's the lifetime management of these patients, as now TAVR is increasingly being used in younger patients. And you can see that if you're in your 40 to 50s, Ross procedure or surgical AVR with mechanical valve will probably be the preferred choice. However, now more than half the patients in the US in certain part of the geography are actually already getting TAVR, even though they're under age 65, which is part of the guidelines. So you can imagine these valves do not last forever. And so they will need to face at least one or maybe even two re-intervention in their lifetime. So the question now is that whether these patients, when they undergo an index TAVR, can actually undergo another TAVR in the future. And so what you see is that a lot of publications have been now since 2020 on this subject, and the literature is still growing, and there's still a lot of unknowns. Now, you can see that here, this is a TAVR explant from the STS database in the United States, showing that it's the fastest growing operation. You can see that here, almost 150% growth between this time period when the low-risk TAVR was approved in the end of 2019, 2020, to now 2023. And you can see I superimpose based on a TVT registry data on Redo TAVR volume, and it's also going up. So you can imagine that this is going to be a problem, an epidemic that we'll face in the next decade. And you can see that here, that the mortality and the stroke actually are quite sobering in terms of after TAVR explant, and majority of these patients were due to structural valve deterioration and all non-structural valve deterioration. We exclude these patients from endocarditis, obviously, which will have no transcatheter option. And you can see this is our own registry on explant versus or redo. We're comparing two groups of patients from same centers. They either go for TAVR explant or redo TAVR, and you can see that majority of the patients undergoing redo TAVR were due to structural valve deterioration. However, if you have severe prosthesis patient mismatch or PPM, you will more likely undergoing explant because the TAVR, a second TAVR is not going to solve the mismatch problem. And also you can see the sobering data on the mortality at 30 days and 1 year of TAVR explant, the red bars versus the redo TAVR in green, in the blue bars. Having said that, if you do a landmark analysis, if these patients survive beyond 1 month, you can see that here the survival curve are really similar between TAVR explant or redo. And in this particular registry, we only included patients we excluded patients rather who had endocarditis, which would not have a redo TAVR option. And you can see that here, this is all the United States. This is a little bit dated now. Looking at the incidence of redo TAVR, you can see it's still very low, about 0.5%, with quite acceptable outcomes at 30 days. And you can see that also, this is from Uri Landis registry, looking at the combination of valve. The issue is that if you have a balloon expandable valve as a first valve or second valve, the risk of the residual high gradient would be higher in this group. So we have to think about how to perhaps make the landing zone more favorable. So this is the Raj Makar's paper from Lancet looking at TVT registry, looking at redo TAVR versus native TAVR with balloon expandable valve as the second valve. And you can see that here, there's really no difference in terms of mortality at 3 years versus native TAVR. If you have the same combination of Edwards and Edwards, or balloon versus inside balloon expandable valve versus a balloon expandable valve in a non-balloon expandable valve, you can see that here, most of them will be a self-expanding valve. There's also no survival difference or mortality difference. However, you can see that redo TAVR does carry a higher residual gradient and lower mean aortic valve area. So you can imagine like a Russian doll effect that you're going to have a smaller orifice afterwards. And you can see that here, if you break it down into redo TAVR with balloon expandable valve versus non-balloon expandable valve, there have been no differences in terms of the death and stroke. However, if you look at the aortic valve gradient, if you, again, similar to what Uri registry found out, that if you do your redo TAVR with in a failed self-expanding valve or non-balloon expandable valve, your gradients are better than if you put a balloon expandable inside a balloon expandable valve. So certainly we're still learning more in this regard in terms of the residual hemodynamics. This is a review paper we published in Circuit Intervention looking at when these valves fail, how do you work up these patients? So typically we find out from a transthoracic echo or TTE. We typically will do a CT, a TEE to understand the mechanism of the valve failure and also to work them up to see whether re-intervention would be feasible. And finally, we even do an aortic angiography to look at for coronary clearance and depth of implant for redo TAVR. So if you look at the right side of the screen here, if they have non-structural valve deterioration, mostly due to paravalvular leak or PVL or PPM with mismatch, if it's mismatch, you really don't have a lot of options. You either have to do surgery, TAVR explant, and put a bigger valve in, or if the patient is not inoperable, and if the first valve, if it's balloon expandable valve, you may be able to put a second valve with a self-expanding valve to optimize the hemodynamics. And we've done that in the past, and it works in certain instances, especially with small transcatheter valves. So if you have paravalvular leak, then really the options are PVL closure. But before that, if you post-dilate and they reduces the paravalvular leak, then you don't have to do anything. And this data has been published by the Vancouver group before. And you can see that here, if you cannot post-dilate, you really have to think about redo TAVR with a second valve to increase the radial force against the seal zone to reduce the leak. And we've done that before, as well with a second valve. Now, if it's structural valve deterioration, ideally, if you can, anatomically speaking, do Redo TAVR because it's safer. If not, then you have to think about TAVR explant, or you can just manage them conservatively if they are not operable. So this paper from Giuseppe Tarantini and myself in JACC intervention, looking at some of the workflow, with CT scan, with some of the coronary obstruction risk in terms of some of the parameters. Common short alignment is clearly one of them, potential sizing criteria, and the positioning. And of course, now we have the Redo TAVR app to teach you all of that. But there are some new vocabularies that you need to learn. So you can see that here, we call neo-skirt concept, the functional neo-skirt, where this neo-skirt plane lies on angiography, the concept of leaflet overhang, valve expansion and deflection. And I'm just going to go over a couple of them because Miho will cover the rest. So this is an example of what's going on with the leaflet overhang. What that means is that when you put the second valve in a little bit deeper, you will have the leaflet of the first valve kind of draping over the orifice. And if you can see that here, these are normal leaflets, obviously, so this is a little bit exaggerated, but you can see they're almost like a two functioning valves going on there. And so the concern is that the second valve, the hemodynamics and the valve leaflet performance and motion may be compromised if you implant the valve too deep on the second valve as a second valve versus the first one. The other thing that we know, and Minneapolis Heart group has published this, is that a lot of these valves are actually underexpanded. So this example of a 26S3, you can see that the parameters, and we definitely oversized a little bit. Nowadays, we would probably put a 23 plus some volume instead. And you can see that here, the valve is really underexpanded. You can see with the mean diameter at the inflow, midframe, and outflow. And so this is a problem, and that's probably why it fails. So what we have done is to optimize this valve to create a more favorable landing zone for the second valve. Because once you put the second valve in, it's going to be much harder, maybe even impossible, to actually expand the first frame further, despite balloon dilatation. So if you can safely expand the first valve further without annular rupture or coronary obstruction out as a result of the valve to coronary distance or STJ distance, then you should definitely do that ahead of time. And you can see we do it ahead of time here and also do it afterwards to minimize the frame-to-frame leak, because now you have a bunch of metals inside each other. The other thing that you need to account for in terms of the risk of coronary obstruction is that this concept, the valve may expand beyond its nominal diameter when you put the second valve in, as you can see here, and you can actually, from the Vancouver group, see that it can expand up to 2.5 millimeters. So now, why do we need to look at the pre-TAVR CT? And people ask this question because actually, once the first valve is in, you can't really tell whether it's a bicuspid or trileaflet, how much you oversize or undersize, because that's important to know whether you can get away with post-dilatation or you need a second valve. You might want to size the valve to the native annulus in addition to in vivo sizing, because you don't want to rupture the annulus, and that has been reported. In addition to that, you can also use the coronary and sinus height references from your pre-index TAVR to kind of do your measurements for your post-index TAVR for planning. So I put together some videos on YouTube. You can watch at your own leisure. But what's been seminal is the Redo TAVR app by Vinny and Miho and their group that they'll go over shortly. Now, what about fluoroscopy? We think that it's actually very high yield because it's high resolution in CT, there are no artifacts, and you are basically kind of doing a dry run for the procedure. You can literally pinpoint which node you're going to target for a self-expanding valve, or where you're going to land in with if the first valve is a balloon expandable valve, so you can clearly see right to the left main how you're going to do that. So, and the view that we recommend is the LAO cranial view, and you take the parallax out of the first half completely and also overlap the cells so you don't get yourself confused. And then you do your aortogram to evaluate the wrist plane, as Miho will talk about that later. So you can see this example here with the portical failure. You can see this is a couple options for you to implant a valve, but this is the sealing skirt here on the lower side. and the top of the leaflets are here. And so because it's a deep implant, you can see the left main here. You can consider the implant about higher at the high position. You can see that here and pin the leaflet completely versus lower and have some overhang. Now, here are 3 examples of why CT scan may be misleading. So the left CT scan looks like the valve was high implant. It's very close to the coronary. And if you see the aortogram, however, it's not the case at all. In fact, with a deep implant, so there'll be no issue with coronary obstruction. Now, the middle case is interesting. You thought that there'll be some room right next to the frame to the left main here. You can see, but you can see the aortogram here that is likely due to an artifact. And so you can see that there's no way, no how you can do a Redo TAVR here other than maybe implant the second valve deeper as a balloon expandable valve to allow some leaflet overhang to avoid complete sinus sequestration. The third case is a SAPIEN Classic. You can see that here it looks reasonable on measurements, but again, when you look at this here on the aortogram, if you plan to expand this first valve, you better be careful not to push it towards the left main, because when you put the second valve, you could potentially create a sinus sequestration situation again and obstruct the left main. So we think that the fluoroscopy is actually very high yield compared to CT, and it's complementary. And you can see that here, these are some of the example combinations of valve. You can see Evolut in SAPIEN, SAPIEN in Evolut. You can see SAPIEN in Navitor. So there's definitely a lot of combinations to consider. So in summary, I think Redo TAVR and TAVR explant for failed TAVR will be the fastest growing procedure in the future. You can see that the short-term outcomes of Redo TAVR are safe, but balloon expandable in a balloon expandable valve may have higher gradients. You'll see shortly the new terminologies and device designs needed to be understood to evaluate the feasibility, planning, execution of the procedure safely. And the Redo TAVR app and also the flow analysis are simple tools, but critical to evaluate the feasibility, valve selection, sizing, and implant position. Thanks very much for the invitation.
Okay, great. Thank you so much, Gilbert. Maybe we'll go directly to Miho and do the questions at the end. I just want to remind our attendees that you can use the chat to ask all the questions you have, and we'll look at them at the end. So Miho Fukui is joining us from Minneapolis Heart Institute, where she serves as an Associate Scientific Director for the Cardiovascular Imaging Research Center and Core Lab. And Miho is going to talk to us about the brand new Redo TAVR app, which she developed with Vinny Bapat. Miho, please go ahead.
I think you're on
mute. You're on mute, Miho.
Thank you. So can you see my screen now?
Yes, we can.
Thank you. So it's my honor and a pleasure to present this topic here today. Thank you, Stephanie and David, for having me. And thank you, everyone, for attending this webinar. So here is my disclosure. So all TAVR devices are made of biological leaflets, which means they will eventually degenerate after 7 to 10 years. When we treated patients with intermediate and high risk, the durability of the valve was not a significant concern because the patient's life expectancy was shorter than that. However, nowadays, we implant many TAVR devices in low-risk patients with longer life expectancy. As a result, a simulation study by Dr. General suggested that in 10 years, the number of patients requiring reintervention after TAVR could be 15 times higher than it's currently. The wave of need for Redo TAVR is coming. So how we can prepare and calculate for optimal result and no complications? It's a bit complicated compared to TAVR in native AS or valve in valve, because we need to consider not only the native anatomy, but also the features of both the index and the second TAVR devices. Here are 2 examples where an S3 was implanted in an index evolute at a similar position. In one case, the implantation was successful, but in the other case, a coronary flow or complication occurred. We must avoid that, but how? Now we know well about valve TAVR in CHUV. Its planning and procedure are well established. The dimensions of surgical valves are maintained and they are implanted as the annulus. So sizing and implant position for TAVR are quite consistent. Furthermore, the valves have a similar height and a relatively low profile, making coronary risk assessment less complicated. On the other hand, transcatheter valves have different shapes and sizes in vivo compared to in vitro. The implant depth of the index tab varies depending on the case, and each tab has a unique structure. As such, the planning and procedure of Redo TAVR are not as simple as TAVR in sub. Systematic CT planning is critical. For that, there are 4 constellations for appropriate case selection and procedure success. First, second tab compatibility. Which second tab types can be used for a given index tab? Optimal implant position for fixation and function. Sizing for appropriate anchoring and functionality. And then coronary risk assessment. Must prevent coronary obstruction on table and ideally maintain future coronary access. So let's dive into each constellation. So first of all, we need to understand each tab structure and its landmarks, as this tells us about where the neoscot frame, top of the neoscot will be, where we should implant, and the relationship with the coronary arteries. In S3 and Meier, the leaflets start at a few millimeters above the inflow and extend up to the top of the commissure tab. In Evolute, each side has unique geometry, but we always count node from the inflow to outflow. The inner skirt covered up at the node 3, and the leaflets start at node 3. For side 23, the leaflet extends to node 5, and for sides 26, 29, and 34, they extend to the node 6. For arcuate, the upper crown and the commissure tabs are the landmarks. So for the compatibility between the index and second tabs, we can simply classify it into 4 combinations: short in short, tall in short, tall in tall, and short in tall. Technically, only Sapien has been approved by the FDA in the US, but tall devices such as Evolute and Arculate are used in the real clinical world. Based on bench testing and early experience, the optimal implant position for short in short is outflow to outflow, and for tall in short, inflow to inflow, aligning at node 3 of Evolute, top of the inner skirt at the top of the S3 commissure tab. This ensures secure anchoring and enhances expansion of the second tab. After the second tab implantation, a tube graft is created by the pinned leaflet of the index tab, which is called as a neoskirt. For CT planning, we propose defining the top level of the neoskirt as the neoskirt frame, NSP. This level could be lower if second S3 is implanted lower in index S3, but it never be lower even if second Evolute implanted lower, but could be higher if it's implanted higher. For tall in tall, no choice, just as the commissure tab. Short in tall, this is a unique combination, since we can adjust the neoskirt frame by adjusting the implant position. Remember that the leaflet starts at node 3, so to treat degenerate leaflet, S3 is needed to implant at least node 4, but no need to higher than the node 6 via the top of the leaflet. So how do we choose the implant position? Ideally, node 6 is preferred since it results in minimum leaflet overhang. However, as you can imagine, this position carries a high risk of coronary obstruction in many patients. We cannot compromise coronary flow. So for such patients, a lower implant position could be an alternative. So next is sizing. Technically, we have 3 options for sizing, but based on our early experience and post-Redo TAVR CT observations, we recommend using in vivo sizing. This recommendation is due to 2 main reasons. First, under and uneven expansion of the index tab is common and can affect the expansion of the second tab. Second, especially for short and tall combination, the size may change depending on the tab size and implant position. Each industry has its own in vivo sizing strategy. For example, for S3, use the average area at 3 levels, outflow with inflow. For Evolute, use average area at the neoscat plane you choose and the 3 nodes below. The app provides such strategy, but cannot recommend the exact size due to variability in vivo dimension. Hence the use the IFU after your in vivo analysis. Last but not least, coronary risk assessment. The first step of it is to identify the coronary risk plane, CRP, which is defined as the plane below the lowest coronary in relation to the landmarks of the index tab. Each patient has a different coronary risk plane based on their coronary height and the implant depth of the index tab. Then assess the relationship between the coronary risk plane and the neoscat plane. When the coronary risk plane is above the neoscat plane, risk to coronary is considered as low, so no need for further assessment. On the other hand, when the coronary risk plane is below the neoscat plane, either or both coronaries are at risk, so further assessment is needed. The next assessment is the relationship between the neoscat plane and ST junction. If below the neoscat plane, below the ST junction, assess valve to aortic sinus VTLOS at the level of the neoscat plane and valve to coronary VTC. If above the ST junction, the neoscat plane is above the ST junction, valve to ST junction is critical in addition to VTLOS and VTC. Then identify the knowledge value among the STJ, VTLOS, and VTC, and apply for this risk classification. This threshold is based on TAVR sub experience. Probably we will need to refine in future. So all the terminology and the concept I introduced today are detailed in a review article just published in JACC Intervention yesterday. Additionally, the app is an excellent resource for this information. And most importantly, it guides you through systematic CT planning and procedure. You can perform CT planning in any way you prefer, but I believe that the step-by-step algorithm we propose here systematically covers almost all important considerations. This is based predominantly on many bench tests conducted in Dr. Sira's Translational lab. So from now, let's see how we can use the app for real case analysis. So once you open the app, here is the home screen, and select the CT planning, you can see all steps you need to do. First step is understand the structure of index tab with reference level and area measurement. We will use this assessment for in vivo sizing later. Next step is identify coronary risk plane. So in this example case, the both bottom of the RC and the LCA at the node 4, so the coronary risk plane is node 4. And select second tab. Once you determine the index and the second tab combination, you'll get an idea about ideal or acceptable levels of the NSP level where to implant. And select the neoscat plane where you want to implant and assess the relationship between the neoscat plane you choose and the coronary risk plane. So for this case, the coronary risk plane at node 4. So if you choose neoscat plane at node 4, the neoscat plane will be at coronary risk plane, so risk to coronary is considered as low. But if you implant higher, node 5, 6, the neoscat plane will be above the coronary risk plane, so need further coronary risk assessment. So, but remember that the balloon expandable second tab could expand the index tab further, reducing the VTA distance, increasing coronary risk assessment. So to do the more precise coronary risk assessment, we need to determine the second tab first. So second step is sizing. So Medtronic recommends the in vivo sizing using the neoscat plan you choose and 3 nodes below. So depending on the neoscat plan, sizing may change. So let's see what happens when we choose a node 6. So we already measured earlier at step 1. So at this point in the app automatically identifies the relevant level, and then you will get the average area. So based on that assessment, you will need to choose the size. So for this case, I will choose size 26, which is one size smaller than the in vitro sizing. And move to the coronary risk assessment with the size. Here are some tips. The first step is assess the relationship with the ST junction. So here at node 6, it's just at the ST junction. So we need to assess the VT SCJ, VT AOS, VTC. And here is the measurement using the virtual circle of the size we choose. And do the same assessment for LCS size. Again, this NSP level is just at the VT SCJ. So need to assess the VT SCJ. And once so now you can see that so even we choose that one size smaller than in vitro sizing, the virtual circle of the size is always outside of the index tab. And in the app, once you enter the value, the app automatically identifies the narrowest value with a color code and gets a summary report at this implant position. So it looks like not good for this case. So let's see what happens if we change the neoscat plan. So once you click this button, you'll come back to the step 4, select the node 5, do the same thing for the sizing. And now at node 5, it's below the SC junction and just at the VTC. So we only need to assess the VTC, but we already done, so we can use the previous assessment. So for LCSI, it's just out a little below the SC junction and a little bit above the VTC. So we need to assess the VT AOS and the VTC. And then, but at this implant position, the narrowest VTA is more than 4 millimeters. So at this implant position, risk to coronary is considered low. Okay, that looks good. And then lastly, let's see what happens for node 4. Just make sure size may change or not. And then for this implant position, no need VTA assessment. So directly you can get the summary report. And based on the, so now you get the summary report at each implant position. And based on that, you can choose where you want to implant. So in this case, I will choose node 5. There are always a few days or weeks discrepancy between the CT analysis and the procedure. So this visual summary will help you connect that analysis and the procedure. And also let me introduce as a function in the app. So here, procedure guide. This simply inform you that where to implant based on the specific index and second tab type and size combination and specific to the implant position. So here, in the case of the index tab is average size 34, second tab is size Sapien 26. Then when we choose node 5, so you will get the images of the final implant position. So here you can get some more detailed information. So not only where the outflow they landed, but also the inflow implant. Also you can find out the different position and then find that such images. Also here I quickly show there are another function, so please play it along. And So I know this is a complicated topic, but I hope you now feel more confident in analyzing and procedure cases. I also hope these resources will help you and improve patient care. Thank you for this opportunity. Thank you.
Thank you so much, Miho. This was great. I think maybe we'll move on to Stephanie Sellers now, and yeah, to the questions at the end. So Stephanie is the director of the Translational lab in St. Paul's Hospital in Vancouver. And Stephanie, you're going to talk to us about THV degeneration, please.
Yeah, thanks so much, David. Can you see my screen?
Yeah.
So hopefully I can highlight today how we start thinking about from the basic science translational side, how degeneration plays into some of the factors that Miho and Gilbert have so expertly outlined, such as expansion, leaflet overhang, those kind of things. Here are my disclosures. And I would just say that doing this work has been possible due to our industry partnerships and then our academic partnerships that allowed us to build the explanted valve registry here in Vancouver and develop a pathology core lab to analyze these types of specimens and work with various partners. And so really when we step back in the lab and look at all the explants and look at how these valves degenerate, we see that, as Miho noted, that all bioprosthetic valves right now are made of materials that will eventually fail in that 7 to approximately 10 to 12 year range. The challenge here is that by looking at these images here, that this degeneration is highly variable. It has different phenotypes, it occurs in different areas. And so really the challenge here is to leverage what we know from surgical valves, but really start to answer what's going on in transcatheter valves and what patterns emerge when we look at that. And so really one of the key concepts is to understand that over the course of that degeneration, that this is a dynamic, ongoing, progressive pathway. This drives progressive leaflet thickening in these valves. Here we can see that in a cohort that we looked at a few years ago, that this implant duration correlates to leaflet thickness. But really the question is what contributes to that process in thickening and stiffening those leaflets. And what we know is that this starts from initial thrombus formation that at the microscopic level we see on all valves. And then within approximately 2 months or 60 days, this progresses to a fibrotic process on these leaflets. And then eventually at 4 years, that thrombus and fibrosis is always found in combination with calcification, leading to stiffening further of those valves, leading us to this progressive pathway that we have to continue to look at and define further. But we can see that even once we know that pathway, that when we continue to look at larger cohorts of valves over time, as these valves continue to be explanted, that this is a heterogeneous process and something that we need to really understand at a more granular level. An example of how we can start to do that is this study that looked at micro-CT mapping of calcium on explanted transcatheter valves. In this case, predominantly self-expanding valves and balloon expandable valves, but one mechanically expanded lotus valve as well. And what you can see here is that there is a varying amount of calcium shown in yellow, but there's also significant gradients that we see in valves that have no calcium on them as well. And so we can start to understand where that calcium forms and how that may have implications for the functionality of that valve. Here's an example of where we can take some of these valves and divide them up by the platforms here, comparing the Sapien balloon expandable platform to the Evolute self-expanding platform, breaking this down into calcium distribution by the middle of the leaflet or on the sides of the leaflet, the free edge, the middle, or the base. In this cohort, we find that the Evolute calcium appears to be more evenly distributed peripherally, meaning we have approximately 60% on the leaflet sides, opposed to the Sapiens that were included here, more primarily towards the center of the leaflet, with approximately 60% in that middle region. We can also see that that calcium is found on both the inflow and outflow aspects of the leaflet. And it's both intrinsic to the leaflet and it both extends out and is extrinsic to the leaflet surface. However, that calcium is encapsulated by an endothelial layer. But what does that mean in terms of functionality? What is interesting is you can take these valves back to the bench and put them in a hydrodynamic tester, similar, like the ones that ViVitro makes, and have these run and look at their functionality when this tester is set to ISO standards. And we can look at the gradients that are created, or the regurgitant fraction, the effective orifice area, for example, of these valves. And in this recent paper that actually just came out in JACC Intervention, what we see is that, in fact, the hydrodynamic gradient, either on the pre-explant echo or in the hydrodynamic tester, did not correlate necessarily to calcium volume. Interestingly, though, it did show that the gradient derived in the tester was no different than the pre-explant echo, showing us that this is a new tool to study degeneration and explanted valves, to start to link the pathology of these valves back to their hydrodynamic functionality. But that's great, and we begin to understand how these valves are actually moving, what's actually driving their pathology and degeneration. But really the question then becomes, in this seminar, what are the implications for that for Redo TAVR? And so this is a study that Gilbert highlighted that was done by one of our fellows, former fellows, Meier, my colleague Janar, that looked at what implant depth should be used for the implant of a SAPIEN 3 into a failed evolute. This was an interesting bench test that looked at leaflet overhang, expansion, post-Redo TAVR gradients. That was informative to the field. What is notable is that this study was done entirely in pristine evolutes that were called the failed index TAVR valve. And so really, if we can utilize what we've learned on the bench from pathology, what we can do is select explants or remake degenerated explants in an artificial means and select some of these and redo this study on the bench. So in this example, we've picked 4 degenerated explanted evolutes of varying degrees of stenosis and calcification. We performed multimodality imaging to assess this, and then performed Redo TAVR with implant of a SAPIEN 3 at node 5 of these failed evolutes, and looked at the hydrodynamics, leaflet overhang, effective orifice areas, and geometric orifice areas to understand how the degeneration of these valves may impact Redo TAVR and refine our previous understanding from Miriam's paper. So here we see that, in fact, all the valves that we selected were stenotic at baseline. You can see they have varying gradients, but all are notable gradients across that valve with varying degrees of calcification on those valves. And then what we can do is implant that new SAPIEN valve and see that in all of these examples, we see that implant to that SAPIEN valve at node 5 reduces increases the EOA, reduces the mean gradient, and reduces the peak velocity across that valve to varying degrees. It does also have an impact on regurgitant fraction. If you look at the right-hand side, you can see that leaflet is not coapting very well. That does have a regurgitant fraction over the accepted ISO standards, telling us that there's factors of the pathology of this valve that is impacting implant of these valves optimally. What we also see is that the leaflet overhang is actually stable on these valves, something that's different from the initial bench test, telling us that the calcification and degeneration of the leaflet is stiffening it and causing that leaflet overhang to be fairly stable between systole and diastole. You can see that the greatest difference here was around 8% throughout the cardiac cycle. That leaflet overhang and the stiffness of those leaflets and the implant at node 5 show us that, in fact, the GOA of the evolute that was degenerated always exceeds the GOA of the SAPIEN 3 and certainly exceeds the EOA, although EOA and GOA are separate concepts. But that's certainly a promising result and something that we've learned from these explants. We can see, similar to the initial bench test, that we still get deformation of that degenerated and stiffened explant. But in fact, we have a significant degree of which the SAPIEN is underexpanded, something that we would hypothesize is related to the thickening of those leaflets and the degenerative patterns of that failed evolute. Here we can see that kind of example, certainly more granular. This is done in surgical valves, but the same concept would apply, where in fact you have calcium or leaflet thickening, which is narrowing the functional area that you have to place a new valve. This is something that kind of relies on that concept of true ID, but in this case, when you look at a degenerated valve, calling that a functional true ID. So how is that actually functionally? How much space do you have for a second valve? A concept that you could translate to Redo TAVR as well. But what happens when that functional true ID is narrowed and the pathology of that first valve impinges on the second valve? Here we see an example from one of those sapien implants in a failed evolute. In the yellow circle there, what you can see is that brand new sapien valve is making contact with protruding calcium from the failed evolute leaflet. And here you see a high magnification photo of that as well. This is actually a concept of where the pathology of the first valve may impact the second valve, something we may want to consider for an initial TAVR implant too. Just pointing out that we know that we place the TAVR valve into a highly diseased native valve, something that we've recently shown that continues to progress over time. And so you have larger nodules and different types of remodeling that occur in that sinus, something that when Gilbert talks about pre or post dilating is something we may want to consider because that area around the index TAVR valve has changed over the course of that implant. This was a study looking at sodium fluoride PET, something that was continued to be avid and continued to increase in avidity over at least a 7-year period in these patients, but also we showed that in exponts as well. Finally, I'll just touch on an example of where we may want to consider pathology of a failed transcatheter valve when it comes to leaflet modification. Obviously, there's different modes to perform leaflet modification. We see an electrosurgical basilica procedure on the left, a shortcut device in the middle, and a unicorn or cleave procedure using electrosurgical traversal, but then progressive balloons and deployment of your second sapien valve and a failed surgical valve. But we may want to consider looking into this more. Here we see an example of an explant in which we have heavy calcification that has been modified mechanically, opposed to another area in a valve that has significant calcification where you have an electrosurgical cut, and looking at the difference in how that calcium may form or the mechanism by which the leaflet modification occurs may change the amount of debris and type of debris that's generated. We can also see that that may have implications for how clean this cut is or the method by which you may want to choose to make that cut. So overall, briefly, so that we have time for discussion, I just wanted to briefly recap how THV durability and degeneration continue to be complex. We have much to learn, including what's going on in the index valve, and that the nature and location of the degeneration may have implications for Redo TAVR, showing that merging pathology and classical bench studies allows for us to refine bench analyses and provide insights to factors that Miho and Gilbert have talked about clinically, such as leaflet modification, leaflet overhang, expansion of the second valve. And with that, I will just say thank Miho and Gilbert again for joining us and remind everyone that our next webinar will be September 18th at the same time, which is a Wednesday at 7 a.m. Pacific. This will be on computational modeling in structural heart with a focus on TAVR. That will be with Zara Mohammed and Hoda Hatam and Jonathan Leipzig and Abdul Idahid, who will talk about ventricular function, calcium formation on bioprosthetic valves, and coronary disease in TAVR patients.